My name is Stacy Pineles, and I am the director of the residency program in ophthalmology at UCLA. Surgery training at UCLA is a multi-tiered and multi-year process and curriculum. In the first year, in the first month, the residents get a surgical mentor. And their surgical mentor is an anterior segment surgeon who's attached to them for their entire 3-year training as a resource for them to use in the wet lab and to bounce ideas off of and to get counseling from. In the first month of residency, the new first years meet with their surgical mentor twice in the wet lab just to get started, to learn how to use the microscope, to do basic suturing, and just general tissue handling. After that, the residents are free to use the wet lab anytime. Also in the first year, very early on, the residents are given access to the IC virtual reality surgical simulator. We have our own novel curriculum that the residents have to get through on the IC in order to gain access to a live operating room. We feel that the virtual reality simulation coupled with the wet lab is crucial for patient safety and resident confidence before they start doing actual procedures. The last thing the residents do during their first year before starting real surgery is the microsurgery course. This is a structured didactic course that's about 4 months long, once a week, where the first years are given protected time. They have a 1-hour lecture with a specialist in the area of surgery that they're learning that day, for example, cataract surgery, cornea transplant, or strabismus surgery. And then the second hour of the night is spent in the wet lab with one-on-one training by the instructor in that area. In this way, all first-year residents have been exposed to every type of ophthalmic surgery in the wet lab with both didactic and hands-on training before they get to the OR. Once they do those 3 components of surgical training during their first year, they're free to start doing real live surgery. Our first-year residents in the end of their first year start by doing a few cataracts, some plastics procedures, and some glaucoma procedures. They also do strabismus cases. These cases are mostly done with them as the primary surgeon. At Oliveview, they'll do primary strabismus surgeries. At the VA, they'll do primary plastic surgeries. And at Harbor, they'll do some cataracts as well as other types of procedures. Starting in the second year, the surgical numbers start to exponentially increase. This is when the second-year residents begin to do cataracts. We have dedicated OR days for cataracts at every outside hospital, and the second years are given very carefully screened cases to begin their surgical training on. They also do many of the glaucoma surgeries at the VA as the primary surgeon. They do primary surgery in oculoplastics, strabismus, and glaucoma on all of their dual Stein rotations. And they also begin to do surgeries as the primary surgeon on trauma call. So they'll do all of the ruptured globes, canalicular lacerations, emergency oculoplastics procedures. This is when they really begin to get comfortable in the operating room. During this time, they also have their surgical mentor, and we have a very communicative network of faculty who communicate with each other regarding residents in their second year and their skill level. If we start to see a resident having a problem with a certain skill or type of surgery, we will communicate with the resident and their surgical mentor to intervene early so that they get into the wet lab and they practice their skills so that by the time they're a third year, we feel very comfortable that all of our residents are ready to go and really become surgical phenoms. And most recently, we've added a cataract and refractive surgery rotation here at UCLA Stein, where residents perform cataract surgery, refractive surgery, including femtosecond laser procedures on patients who are patients at the UCLA Stein Eye Institute. We give these patients discounts on premium intraocular lenses and femtosecond laser in order for them to feel comfortable allowing a resident who is fully supervised by a faculty member be their primary surgeon. We recognize that residents need a little bit more training in order to be safe, both for the patients and for their own self-esteem. We want the residents to feel really good going into the operating room so that they feel comfortable and don't have any of the sort of side effects that you can have from being very nervous and unpracticed. We want the residents to use all of the tools that we've provided them with, which includes microsurgery lab training and didactics, virtual reality surgical simulator, backing into cases where they do a small portion of the end of the case and slowly increase backwards to the front of the case. All of these tools give residents the confidence they need so that when they do tackle their first case, they feel comfortable. We as a program feel comfortable that the patient is safe and the resident is set up for success. We provide all these tools and want them to use the tools so that the residents feel confident going into the OR for their first full case, and that we as a program feel confident that the residents are safe to perform surgery, and overall we set the residents up for success. So many people ask how we provide our residents with feedback. And just like surgery training, feedback is a multi-tiered system. At the very sort of lowest end of the scale, but very important end, is real live feedback that we provide in the moment. We examine a patient with a resident and tell them that they didn't see something or explain to them what they were looking at. We talk to them in the middle of a surgery and say, grip it tighter, move it faster, whatever. Something in the surgery where we're providing real in-the-moment feedback. Many times that's not recognized as feedback, but that is often the most important feedback, and we try to provide that every day, all day long. In terms of more formalized feedback, every resident does a fully observed patient encounter on every rotation where an attending sits in the corner and watches the resident from beginning of the encounter to the end, and immediately after goes over a checklist evaluation just to simply give them some feedback on their interaction with the patient. How are they doing with the history? Do they interact in a professional manner? How is their exam? What about counseling the patient? Those sorts of things. We also do a surgical evaluation after every single procedure that a resident does. This evaluation uses iPads and a cloud to store data so that residents receive weekly or monthly feedback aggregated to be able to track their progress. In addition to these surgical evaluations and clinical observations, we have typical evaluations after every rotation, which is done by faculty, peers, staff and nurses, and also patients. In this way, we get a 360-degree evaluation of every resident. With these evaluations, we meet twice a year with a clinical competency committee, which is made up of 6 faculty members who work closely with the residents. We review hundreds of evaluations for each resident, and then we score them on the milestones that are provided by the ACGME. The residents receive these scores twice a year in a one-on-one meeting with me, where we look at their scores, what their strengths and weaknesses are, and also compare them with national averages and averages at our program. Through this mechanism, the residents are provided with very formal feedback from me and my committee twice per year. They also meet with a mentor who is assigned to them twice a year and also has access to all of their evaluations. This mentor provides more personalized feedback and is typically a person who is situated either in the field that they're interested in or in another way connected to them through common interests. It's hard to really pinpoint one thing that I like most about running the residency program, so I may have to say a few things. First of all, having been a graduate of this program, I have an immense source of pride and loyalty to it, and to see myself and others be able to improve upon it is one of the greatest joys of my life. It's always been an extremely strong program, but the changes we've been able to make in the past 8 to 10 years have really taken it to a different level by making it a little bit more organized, friendly, yet maintaining the utmost level of expectation for our residents and training them to become the top surgeons and clinicians in the country. So of course I like that about it. I love working with residents. I'm a mom of 2 children, but I always think of myself as a mom of 26 children because I have my own 2 children and then the 24 residents who I really care deeply about and think of them for those 3 years as my kids. And then the minute they graduate, they're my colleagues. And watching each and every one of them go on and accomplish amazing things, there's nothing more gratifying than that in all of medicine. How do I bond with residents? I bond with them in some formal ways and some informal ways. We have a lot of events at Stein that we get to interact with the residents on a social level. I always have all of the first year residents and their partners and children over to my house in the first week of July when they arrive. I have them meet my kids. I let my kids play with their kids. And I enjoy meeting their spouses, and we have a really nice dinner. At the end of that dinner, I invite all of the second and third year residents over. We share dessert and drinks, and then I tell the residents to all go out together without me since I'm getting old. So that's always the first time where we really get to interact and bond on a level where we're more comfortable and we're not part of the recruitment process anymore. After that, I enjoy having the residents over to my house for a journal club and meeting them at other venues. We have a social happy hour 3 times a year. And at our residency retreat, we do team building exercises. Most recently, we went bowling. We've also done escape rooms, and we have a ropes course that we do here at UCLA. So we do a lot of really fun stuff. And of course, we travel to meetings together. We have social events at Academy, ARVO, ASCRS, where we all interact and have fun together. And then at Stein, when they're on my rotation, I get to work closely one-on-one with them in the operating room. And there's nothing more bonding than attending someone in their first year business surgery. So we bond on a professional and personal level, and I think many of the faculty would agree that's one of their most favorite things about working with residents. I've been asked what I'm most proud of when I look at my residents, and I have to say, this might be a surprise, but watching them in the operating room during their third year gives me immense pride. Sometimes, very rarely, I attend cataract surgery as a pediatric neuro-ophthalmologist at all of you when the residents are very advanced along their career. And the reason I like to do this is to watch them as sole cataract surgeons and watch them see their skills. They're such amazing surgeons that I would let any of them operate on my own family members. And to watch that progression from a first-year resident who doesn't know how to hold an instrument to a surgeon that I'd feel comfortable letting operate on my mother or father is the greatest source of pride that anyone could have.